hablo en español, ¿no?
En español, sí, en español, Tenemos la traducción, ¿no? Para que nos entiendan todos los compañeros de 12 países que nos están viendo, como siempre, ¿no?
Ok.
Estamos en vivo.
¿Qué tal a todos? Muy buenos días. Gracias por conectarse a esta sesión webinar desde la Unión de Universidades de América Latina y el Caribe y la Asociación Latinoamericana de Facultades y Escuelas de Medicina, la ALAFEM. Bienvenidos a esta sesión webinar, Retos de la Importancia Médica en Tiempos del COVID-19, con el tema Importancia de la Acreditación Internacional. Recuerden que estamos transmitiendo en vivo desde esta plataforma Zoom y además también tenemos una transmisión simultánea desde el Facebook de la Facultad de Medicina de la UNAM. Gracias a todos los organizadores, gracias a todo el personal académico, investigadores, rectores que están conectados el día de hoy desde América Latina y el Caribe. Bienvenidos, la UDUAL y la ALAFEM les da la bienvenida a todas y todos ustedes. También recuerden que tenemos justamente el día de hoy una sesión muy especial, por lo cual tenemos habilitado el sistema de interpretación simultánea. Ustedes en su canal de Zoom pueden escoger en la parte de abajo el canal que quieran en español o en inglés. Así que daremos inicio a esta sesión. Bienvenidos a la gente que se está conectando gradualmente desde distintas partes de América Latina y el Caribe. Muchas gracias. Le pediría al doctor Roberto Escalante Semerena, secretario general de la UDUAL, que pudiera darnos un mensaje. Adelante, doctor.
Gracias, Germán. Muy buenos días. Saludo muy afectuosamente a nuestro apreciado doctor Germán Fajardo Dolci, director de la Facultad de Medicina de la Universidad Nacional Autónoma de México y presidente de la Asociación Latinoamericana de Escuelas y Facultades de Medicina de América Latina y el Caribe, una asociación muy importante ligada a la UDUAL. Y también saludo, espero que mi alocución en español les llegue a ellos, al doctor William Pinsky, al doctor David Gordon, también a la doctora Irene Durante Montiel y al señor Martín Hart. Todos ellos invitados muy distinguidos para esta sesión. Muchas gracias a todos los que nos siguen. Estamos seguros que no solo en América Latina y el Caribe, sino en muchas otras partes del mundo. Bueno, el tema de hoy es un tema, yo diría, secular, de gran importancia, que la ALAFEM y los organismos nacionales mexicanos y de otras partes de América Latina y el Caribe le han dado, en este caso a la educación médica, que es el tema de evaluación, con el objeto de garantizar, estar pendientes de los sistemas de calidad de la enseñanza médica. Y esto en el marco de la globalización, en donde la medicina, y en el marco de la pandemia, en donde las ciencias médicas han pasado a ocupar un lugar absolutamente preeminente, se convierte pues en un tema de discusión, de análisis, porque los médicos están hoy siendo actores fundamentales y hay grupos de médicos, incluso de algunos países, que se mueven a otros en el auxilio para lidiar con todos estos asuntos de la pandemia del COVID-19. Entonces, yo le quiero agradecer muchísimo al doctor Germán Fajardo la iniciativa de haber organizado esta esta sesión para discutir con tan distinguidas personalidades que tienen que ver con el tema de la acreditación, de la calidad de la educación médica en diversas partes del mundo, de manera muy importante, en los Estados Unidos, en Inglaterra, en el Reino Unido, en fin. Hoy sus invitados son gente muy importante. El mismo que está al frente de la asociación. Y también la doctora que nos acompaña, la doctora Irene Durante Montiel, que ella es la presidenta de la Comisión del Consejo Mexicano para la Acreditación de la Educación Médica, también un espacio realmente muy importante. Entonces, una espléndida sesión, una sesión realmente muy importante que nos va a dejar enseñanzas, pues, que valdrá mucho la pena atesorar para trazar tareas futuras respecto de esta preocupación permanente y, como decía, hoy más que nunca, como es el tema de la acreditación de la calidad. Entonces, doctor Fajardo, muchas gracias y por favor, tome la conducción de la sesión. Muchas gracias.
Muchas gracias, doctor Escalante. Muy buenos días tengan todos ustedes. Un gusto saludar a los compañeros que nos acompañan prácticamente de 12 países de América Latina y España. Agradezco que podamos coincidir de manera muy importante al doctor William Pinsky, al doctor David Gordon, al doctor Martin Hart y por supuesto a la doctora Irene Durante, la posibilidad de estar juntos esta mañana para hablar de los retos de la educación médica en tiempos de COVID. En particular, para hablar de la importancia de la acreditación de escuelas y facultades de medicina. De escuelas y facultades de medicina, en este caso la acreditación internacional, es donde nos queremos enfocar. Sin lugar a dudas, vivimos la mayor crisis contemporánea de la humanidad en los últimos décadas, probablemente en los últimos siglos. Nadie tiene todas las respuestas, más bien tenemos todos los días más preguntas y todos los días aprendemos algo de manera conjunta. ¿Cómo estamos respondiendo como escuelas y facultades de medicina? ¿Cómo estamos respondiendo ante estos retos? ¿Qué tenemos que hacer en estas condiciones para que los futuros médicos que están aprendiendo las materias básicas, que están aprendiendo las materias clínicas, o aquellos que ya se encuentran en posgrado, o incluso si hablamos de educación continua, cuál es nuestra responsabilidad ante estos hechos que estamos viviendo? Decimos ya que es un tiempo sin precedente. También durante los últimos años, antes del COVID, sin lugar a dudas ha cambiado la forma de enseñar y de aprender medicina. Se ha transformado la pedagogía, la manera como se enseña la medicina. Tratando de tener cada vez, por supuesto, menos clases teóricas, un contacto no solo cercano, sino rápido, ya sea con simulación o con el paciente, con un aumento en la atención primaria a la salud, centrado en competencias, con trabajo en equipo, teniendo cada vez más enseñanza interprofesional y actividades profesionales confiables, entre muchas otras cosas que se vienen haciendo en la educación médica desde hace varias décadas. Sin embargo, nuestra nueva realidad hace que no podamos llevar a cabo actividades de clase como la teníamos en el salón de clases, ¿no? Las actividades de laboratorio, las actividades en biblioteca y por supuesto también algo que nos preocupa mucho, las actividades hospitalarias. En otras circunstancias de crisis, los estudiantes de medicina siempre estaban en la primera línea de batalla, ¿no? En los casos que hemos vivido de cuestiones naturales, como son temblores, como son otro tipo de eventos, los estudiantes de medicina siempre estaban en la primera línea de batalla. En este caso, como es natural, no pueden estar. Y esto ha dificultado no solo la ayuda, por supuesto, sino la enseñanza de la medicina, que es el tema que hoy nos convoca. Esta experiencia, sin lugar a dudas, modificará para siempre no solo nuestras vidas, sino la educación médica en el mundo. La acreditación de escuelas y facultades de medicina, ya sea una acreditación nacional, ¿no?, o una acreditación internacional, buscan, sin lugar a dudas, tratar de garantizar la calidad de la educación médica de los egresados, para que cumplan con su misión social los egresados, los futuros médicos, y que se cumplan con los estándares mínimos de calidad y asegurar las competencias necesarias para enfrentarse al futuro. Hemos dicho en otras ocasiones que a los alumnos debemos de enseñarles a aprender medicina para siempre, no solo aprender medicina. Con esta idea y en estas circunstancias tenemos que ser congruentes, incluso en el momento que nos encontramos. ¿Cómo adaptarnos entonces a la educación a distancia? ¿Cómo cambiar a la educación no presencial en el área médica, particularmente en el área clínica? Enfrentamos pues grandes retos, incluyendo por supuesto la formación docente. Ahora no solo la formación tradicional, sino formación en educación a distancia, con los retos que incluyen la adaptación, la innovación y la modificación ante estos nuevos hábitos que estamos viviendo. Situaciones extraordinarias como las que vivimos requieren sin lugar a dudas respuestas extraordinarias. Y por eso estamos hoy aquí, para juntos tratar de encontrar estas respuestas y seguir ofreciendo la mejor educación médica a nuestros alumnos. Con esto agradezco nuevamente a los panelistas que hayan aceptado estar con nosotros, y le daremos inicialmente la palabra al doctor Martin Hart, quien es director adjunto del Consejo de Médico General en el Reino Unido. Adelante, por favor, doctor Hart, te escuchamos.
Thank you. Can you all see my slides?
Yes, we can.
Looks as though you can. Good. Thank you, and thank you very much for the invitation to join you today. My name is Martin Hart, and I am the Assistant Director in charge of Accreditation and Quality Assurance of Education and Training at the General Medical Council in the UK. What I'm going to do just for a couple of minutes is just a few slides on the UK approach to accreditation. These aren't specifically about the COVID issues and the issues that we were just being introduced to, which I think will be a real great subject for debate later on. But I'll just take just a few minutes to let you know a bit about the UK situation. The General Medical Council, as you may know, is the regulatory body for the medical profession in the UK. It is independent of government. It is funded actually by the doctors themselves, who pay an annual fee to us. And we have four key areas of responsibility. One is to maintain the register of doctors in the UK. We also promote high standards, both ethical and clinical standards in the UK, and set those standards. We also deal with fitness to practice, so dealing with those doctors who fail to meet those standards, and in a very small number of cases have to be removed from the medical register. And the area that I work in is to oversee the education and training of all doctors in the UK, both at undergraduate level and in their postgraduate training as well. Just a quick apology to particularly Irene and Mexican colleagues. They will have seen this presentation before, so if you want to have a little sleep for the next 4 minutes, feel free to do so. I'll be fairly brief anyway. So in education, we're responsible for regulating all stages of medical education. So from the first day at medical school, right the way through postgraduate training, and indeed through continuous professional development throughout a doctor's career. In the UK, we have undergraduate medical education, and I'll briefly describe that. We then have a program called the Foundation Program, which is 2 years of training after medical school, where doctors typically sample up to 6 different specialties. They then enter their specialty training, and they then, when they complete that training, obviously we're very keen that they continue to develop throughout their career. This diagram just shows that training pathway. So going left to right, in the UK, students typically go to medical school for 5 years. Some go for a bit shorter. Then we have this foundation program that I described, which has 2 years. At this point, they are doctors, they are in training, they are registered and licensed by the GMC. There's then the brown bit, which is the postgraduate training. That varies in length depending on the specialty chosen. So family medicine in the UK is the shortest, about 3 years. Other specialties are up to 8 years. And then once you complete that, you go on what we call the specialist or GP register. You can be a consultant in the UK Health Service, and that's the rest of your career. You'll see at the top, there's various stages of registration with us. We provisionally register doctors at the end of medical school, and they then have a year. The first F1 year is akin to an internship in many other countries before you get fully registered. And at the end of specialty training, you get what's called a certificate of completion of training. Basically means you've completed your training to be a doctor. Undergraduate education is delivered throughout the UK, as you can see from this map. There's about 35 medical schools in the UK. We've got some new medical schools coming through as well. We've got 5 new medical schools being developed in the UK. Just over 40,000 medical students in the UK at any one time. We allow medical schools to develop their own curricula and assessments, but they do this under a framework that we set, which is a document which I'll show you called the Outcomes for Undergraduate Education, which is a high-level document and sets out what the GMC expects a doctor to achieve when they graduate. It was known as Tomorrow's Doctors in the past, which I always thought was a very good title for it because it's about the doctors of the future, but it's now called the Outcomes for Undergraduate Education. We are, however, contemplating the introduction of a medical licensing assessment, something not quite the same as USMLE, but something that brings a greater standardization to the end of medical school. A lot of the course is delivered in and by the NHS, and the point that was just being made about the challenges of teaching in clinical environments during something like a pandemic is certainly something that I've been giving a lot of time and thought to in the last few weeks as we seek to make sure that we can carry on training doctors no matter what happens in the future. And we, as a GMC, quality assure and accredit all those medical schools. This is the document I just thought I'd show you. It's available on our website. It's the Outcomes for Graduates. We review it fairly regularly, actually. Reviewed it in 2018, and we'll probably take another look at it in a couple of years' time. This document, and again, it's on our website, is what we call Promoting Excellence. And this is the standards we set for those who deliver medical education and training. And we have the same document, the same framework for both undergraduate and postgraduate. So there's actually 5 themes here, 10 standards and various recommendations. I'll just highlight the themes because I think they're important. These are the things that we really focus on when we're looking to accredit medical schools and indeed postgraduate training. So the learning environment and the culture, what the medical school is like, what the hospital or the other clinical environment is like, whether they're lined up to deliver good quality education and training. Theme 2 is around governance and leadership. Does it have the structures in place and the leaders in place to deliver good quality education and training? Theme 3 is around supporting those who are learning, whether they're students or trainee doctors. Theme 4 is around supporting those who do the teaching, who are never more important than at the moment, the doctors and the others in the clinical team who are training our students and doctors. And the 5th one is that the curricula and assessments are being developed appropriately and implemented for whatever stage of medicine the learner is at. So that's the key framework that we always work from when we're doing quality assurance and accreditation. This diagram just illustrates the different people who are involved in accreditation and quality assurance. So we are at the top of this sort of pyramid. We're quality assuring what goes on below. The middle layer is the medical schools and the postgraduate bodies in the UK. We have a system of what we call postgraduate deans who are responsible for overseeing postgraduate training in the UK. And then the third layer is the local education providers, which quite often is obviously acute hospitals, but increasingly as medicine is being taken out into the community and more delivered by family medicine, is really anyone who is delivering medical education across the UK. And this way, we hope everyone understands their role in the system. Finally, just a brief explanation of some of the tools we use in our classic accreditation of medical schools. Our process involves looking quite closely initially at the documents and the material that a medical school produces. We then put together what we call a visit team, and these are our people who actually go out in normal times and visit students and doctors in training in universities and in clinical environments. And we put together quite varied visit teams. We do have doctors on it, obviously. We do have those involved in medical education, but we do use lay people as well. These may be people who are not doctors but work in healthcare, or they may be people who work in other areas of education, for example. And another thing that we've done for many years is have students on our visit teams. They are key members, they're equal members of our teams who clearly bring a real student insight to what it's like to be at a medical school. That visit team will look at those documents and we'll look at that promoting excellence diagram and look for where they want, the areas they want to explore when they go and visit students in their universities. On the visits, we tend to meet a whole range of people separately. We'll meet the senior management of the college, we'll meet the students themselves, talk about their experience, and we'll talk to the clinical teachers, the people who are teaching them. And what we'll try and do is triangulate all these views to get a clear impression of what it's like being taught at that particular institution. And then at the end of our visit, we feed back to the institutions. We talk about the requirements. There may be things that we really think they have to do, and we'll tell them very clearly to do that. Sometimes we'll make recommendations. We'll say, you know, you may like to do this a slightly different way. And we always try, if we can, to highlight areas of good practice. I think it's really important in medical education that as we hear of different innovations, whether in the UK or around the world, we share them with them as well. And to that end, we publish reports, publicly available reports. They're available on our website of every institution we visit. Transparency is a key element to what we're about. I'll probably pause there, but I hope that's given you a flavour of the context for the UK, and I look forward to the discussion about where we are in these very unusual times when colleagues are presented too. I hope that's helpful.
Muchas gracias, doctor Hart, por su presentación. Y enseguida le damos la palabra al doctor William Pinsky, quien es presidente y director ejecutivo de la Comisión para la Educación de Médicos Graduados en el extranjero en Estados Unidos. Adelante, por favor, William.
Good morning. Thank you very much. Let me get my screen shared here. Okay. There we go. Can everybody hear me and see the screen? I can't see anybody, so I'm hoping you say yes.
Not sure we can see the screen yet. We can hear you fine.
Oh, okay. I thought I just shared it. Let me try again.
Now we can, thank you.
There you go. Yep.
Yeah, sorry about that. Okay, we're good. So good morning, everybody. I apologize for speaking in English. Back when I was in middle school and high school, my mother insisted that I take Latin and French and not Spanish. And even though my mother always had good advice, it hasn't helped me in my professional career. So I apologize for that. Thank you for the opportunity to be able to talk with you today. I think as we all go through our own issues within our own communities, countries, and institutions, we have some common issues we deal with and some other specific ones. What I'm going to talk to you about this morning is how ECFMG FAMR has needed to pivot in dealing with certification of international medical graduates for this upcoming year. This has to do, the reason we've had to change has to do with the United States Medical Licensing Exam having suspended the clinical skills exam, which is a very important part of ECFMG certification. So I will go through some of our changes with that. And then I will also have a few brief comments to make about what we previously called our 2023 Accreditation Recognition Program that we now refer to as our 2024 program. And I'll talk about that. So just as a reminder, ECFMG has operated almost continuously for 70 years. ECFMG was formed, and that's the Educational Commission for Foreign Medical Graduates, in order to certify individuals who graduated from medical schools outside of the United States and Canada and wish to come to the United States for further training. The certification process, as you all know, has to do with identifying individuals or certifying that their identity is what they say it is, that their medical school diploma and curricula are genuine, a review with the United States government, with people's past behavior to be sure that nobody should be is coming in that should be precluded because of past activities, usually a criminal activity of some sort. And then we register individuals to take the US MLE exam. And so the requirements that we set are really entirely up to ECFMG as we assure the public that individuals with whom they will become in contact have had the proper training in experiences, and the program directors who are evaluating potential candidates for training have a proper background as well. And I'll probably mention several times as I talk with you, particularly in this post-COVID, well, I guess we're not post-COVID, in the COVID era, that how important it is to maintain proper standards. And I think the public really requires that we do that. So over the 70 years, or almost 70 years, ECFMG has continued to modify the standards with which we use to certify individuals, and a demonstration of clinical skills as well as English language proficiency and ability to communicate with patients have always been requirements. And so with the closing of the USMLE clinical skills exam, we have put in a surrogate pathway for 2021 in order to certify individuals. We feel that this pathway will indeed maintain the integrity of our certification process, which means we continue to assure the public, assure program directors, the people with whom they'll have contact are appropriately qualified, and we are attempting to do this without significantly disrupting anyone's professional aspirations or pathway. So just as sort of a brief overview in terms of the ECFMG certification criteria in the pathways, again, it's to assure the public in the GME programs that people are appropriate to come in, and the use of English language is, of course, very important. And we want to assure that there is a qualified pool for the residency match for next March. And so we've had to use existing measures that we've been able to adapt and adopt to be able to meet this. So there are 5 pathways basically. And I'll go through the pathways very briefly, but I also will point out where you can find the details of these pathways on our website. In addition to the 5 pathways, everyone, and it doesn't make any difference what their country of origin is, but everyone must be able to demonstrate an English language proficiency assessment. The certificate that we're going to give people that come through this new pathway is going to be subject to expiration. And I'll talk about that in just a minute. And then there's overall general eligibility requirements. And I've learned over the years that it's always important to have very strict policies and procedures, but one needs to apply those with a brain. And therefore, we do have an exception process because we recognize that there may be some legitimate reasons why somebody might not meet one of these criteria, and it's something that we're willing to consider. So here are the 5 pathways. Pathway 1 are individuals who are already licensed to practice medicine in another country. These would be individuals who have gone through medical school, received their license in another country, frequently their home country, and have been practicing without interruption and without interruption of their license since receiving it. And of course, we only want people that have had no disciplinary action. Second pathway has to do with demonstration of clinical skills. And we know that there are several countries, probably many countries, but several countries we're aware of at the beginning of this process that require an OSCE, a clinical skills exam, in order to receive their medical license to become registered in that country. We've expanded that also to include situations where an applicant has passed an OSCE exam within their own medical school, and that country uses that exam for licensure purposes. Third is medical schools have been accredited, and that have been accredited by an agency that WIFME has already recognized. And as part of this graduation, can have their clinical skills attested by a recognized school official. The 4th pathway, I'm sure many of you know that there's almost 24 schools that the United States Department of Education recognized to be eligible to receive federal funding, US federal funding to students, the federal loan program to assist in their medical education. So we will include those schools as well. In fact, about half of those schools have already been accredited by a recognized WIFME agency. And then the 5th pathway, we know that there are at least 2 schools that share a curriculum that is accredited by the LCME. And these are the schools that are in partnership with Cornell University and Duke University in the United States. As I mentioned before, everyone is going to need to demonstrate English proficiency, no matter what their citizenship and native language is. And we have decided to partner with the OET, the Occupational English Test, which is a product of a consortium out of Cambridge University. I believe the GMC, Martin, also uses OET, and I think, in fact, your staff probably tipped us to reach out to OET. And what we like about OET as an occupational English test is that they have a medical stream, so that the test involves medical situations and not just a general medical language. I mentioned earlier that the certificate that individuals will receive is not going to be the usual certificate. It's going to be a certificate that's time limited and subject to expiration. So those individuals who successfully are granted this time certificate and then go on to successfully get into a U.S. residency program, when they finish their first year of training, then their certificate will become permanent. For those who are unsuccessful in getting into the a residency program, their certificate will expire and they will have to go through what our more permanent process will be beginning in 22. So some of the general eligibility requirements and red flag restrictions. We're really concerned about not having individuals who are using COVID as an opportunity to try to slip through the process that perhaps previously they would not have been qualified. And for that reason, we're really interested for this 1 year in individuals who have been in process, who are relatively newly graduated and or been licensed previously in another country. So individuals who have not been in the process for certification prior to 2018 will have to wait another year. Likewise, because we're concerned about the quality and qualification aspect, we are restricting individuals who have failed any one of the USMLE steps, which would be step 1 or step 2 CK, more than once. If they failed each one once, they are included. And the reason we're doing this is we're using as a surrogate program directors' favorability, whereas individuals who have failed an exam, any exam one time, still have close to a 50% chance of matching historically. If anybody has failed an exam more than once, then they're unlikely, like less than 10% opportunity to get into a program. So we're using that quality index from program directors, and that's why we're for this 1 year, only including individuals who have failed an exam once. And then, as you can imagine, individuals who have been sanctioned by ECFMG or USMLE for improper behavior or by their licensing authorities are going to be excluded. I mentioned that we're trying to put a brain with this, and we will consider exceptions. And the one exception that we're most concerned about are individuals who may have been in the process longer than we wish, as you saw in prior slides. However, we do recognize that many very qualified people will interrupt the process to pursue a higher degree, to become involved in meaningful research. And for that reason, we're willing to listen to applications for exceptions, primarily for those reasons. I will direct you all to our website, as you can see in these slides, and I hope that the organizers will make slides available to all of you so you can have this to refer to. We update this website frequently. In fact, I think it was updated as recently as last night as we get questions and people are asking for clarifications. So the issue in terms of the medical school accreditation recognition process that you all are aware of. Currently, there are 21 plus, David, I think I've got the right number there. You can correct me when you speak, that have been recognized by WFME. And I believe there is a significant lineup right now of schools, and David will probably talk about that, or countries that are in process, and I'm sure David will talk about that. We are very encouraged about this response because it really means that countries are understanding the importance of quality assurance in their medical education. Because of COVID, and knowing that people have had to turn their attention to other things, and that the review process, it has been slowed as travel has been slowed. We are moving our effective date currently from 2023 to 2024. We really hope that this will not discourage the enthusiasm that is out there, and that the momentum is kept up. But we also recognize the reality that COVID has brought. And we'll look at this timeline. You know, if there's a significant resurgence of the virus and we need to delay it more, we will consider that. But as of right now, we are moving the timeline to 24. I hope I haven't gone over my time too much. I apologize if I have, and I do look forward to questions later.
Muchas gracias, doctor Pinsky, por su presentación. Y sí, dejaremos, si ustedes ahí nos lo permiten, las presentaciones de cada uno de ustedes de acceso libre para que la gente las pueda consultar, para que la gente las pueda ver en cualquier momento. Enseguida le pedimos al doctor David Gordon, quien, como ustedes saben, es el presidente de la Federación Mundial de Educación Médica, que nos haga favor de hacer su intervención. Adelante, David, por favor, y muchas gracias nuevamente.
Thank you very much. It's a great pleasure to be invited here, and a great pleasure to be talking at a meeting with a Latin American audience. I've had many messages from friends out there who are watching, so thank you very much, and I know you're there, Maria. I'm from the World Federation for Medical Education, and for those who do not know us, we are the non-state actor that is responsible to WHO for the quality of medical education worldwide. And we were founded by the World Health Organization and by the World Medical Association about 50 years ago. Now, I have no slides, and I'm going to just introduce really 4 important topics, and I'll come back and summarize what they were at the end. Last time I spoke at a meeting centered in Latin America, I opened by noting the greatest, for me, novel in the Spanish language, Love in the Time of Cholera by Gabriel García Márquez. He was making the point that even during the cholera epidemic that was sweeping Latin America in the late 19th century, love was still there. And I could give a subtitle to say I'm talking about medical education in the time of COVID. The epidemic is there, but we still have to continue educating our students, running our medical schools, accrediting education, and making sure that the quality is right. So the first point I want to make is that I think it is very important that medical schools take a leadership role, not just in education, but in helping society to think about how they cope with this pandemic. Our world has been turned upside down, and not only has it affected education and healthcare, but it has affected many other things as well. But I think it's important to remember that while it's essential that we protect our patients as far as possible from the effects of the disease, that we do not make things worse by what we do. For example, I believe it's very important, as far as possible, to keep education in schools continuing, provided it's safe, because the damage to school children, if education comes to a stop, is very profound. And that may have profound effects, not only on their health in the long term, but also on their ability to develop themselves, to develop into a career, to function in society. And I think we have a duty to actually make sure that the rest of the world understands that. I'm not going to say that something like President Trump or President Bolsonaro to say that the epidemic isn't happening and let's carry on doing everything. I think it's very important to have a balanced approach that protects the population, make sure that healthcare continues, but also make sure that really important other things continue as best as they can. In the context of the UK, for example, my own view, and I'm sure Martin will agree, I think it's very important, much more important to keep schools functioning well than to have the pubs open. We can do without a drink for a few weeks, but we can't do without education. So that's the first point. We must lead and make sure that things are working in a sensible way. The second point I would make is that we have been here before. This is not the first time that the world has been devastated by a very large pandemic. The example that we often think of is the influenza about almost exactly 100 years ago. But 30 years before that, Europe was devastated by cholera. 70 years before that, India was devastated by smallpox. Several hundred years ago, the world was devastated by the bubonic plague. And yet society continued to function, and we have to make sure that we function through these things, and at the end we continue to go back and work as well as we can. So we mustn't regard it as something that's happened now and has never happened before. I agree absolutely with our host at the start that this is the biggest event for many, many decades, but it is not unique. And I think there are lessons to be learned by the way that our predecessors managed to work their way through those earlier epidemics. And I hope we create lessons that our successors will understand when the next pandemic comes along. The third point I would make is that we need to see what is going on. What do I mean by that? Clearly, for example, we need to see our patients. I'm slightly disturbed by the way in which the British government feels that a lot of medical practice will all be done over the internet or over the telephone. I've had 2 excellent telephone conversations with my doctor, but you cannot deliver a baby over the telephone. I think a psychiatric consultation at a distance may be difficult. And certainly from my last consultation, the promise that a blood test would be arranged has not happened. So we do need to see our patients, and recognizing that we can do a lot of medical things at a distance, and many things, diagnostic things, will be done more efficiently in the future with artificial intelligence and so on, but we still need to see things. And not only do we need to see our patients, but we need to see our students, and we need to see our medical schools. If you are an accrediting agency evaluating whether a medical school is doing its job properly, it may not be possible to visit them at the moment, but anyone who has been involved in accreditation of medical education will be aware of the occasions when a medical school looks good on paper, but you go there and start to talk to students or start to open the doors that the medical school wanted to leave closed, and you discover that things are nothing like as good as they looked at first. So to make a proper evaluation of a school, and we may have to postpone this at the moment, but to make a proper evaluation, you need really to see what is going on. And in our own case, when a large part of our work is assessing accrediting agencies, we believe that it is very important to do so, including a site visit to see the agency in operation. We have had 2 instances where things looked all right on paper, But once our team was there on the site visit, it was clear that there were serious problems. Those applications, as it happens, were withdrawn, and one of them has already come back, revised, and the agency has revised its practices, and that agency has sailed through with complete success. So if you do not observe what's going on, you cannot be sure that it really is working according to the rules and according to what the agency said. Dr. Pinsky alluded to the number of accrediting agencies that have already been assessed by the World Federation. The up-to-date number is now 23, and there are about 25 more who are either very close to assessment or will be ready within a year or so. Of course, we have not been able to send teams out to make the evaluation, but we have several ready to go as soon as travel becomes more practical. And I'm sure that we will actually start to be able to do that within the next 6 months. And certainly there's no lack of demand from our colleagues in accrediting agencies for an assessment by the World Federation. So I've said 3 things. First, that medical schools must lead, that we have been here before, and we need to see what is going on. And the 4th and final point I want to make is to come back to the medical student and the education of that student during the time of this pandemic. I think it's very difficult because students need to learn, and they need to learn in a way that is acceptably safe, but we need also to recognize that students will need to be exposed to difficult things. I was disturbed by a report in one of the British newspapers about an advanced form of clinical teaching done at one of the medical schools in London. And this was obviously a very good program, where not only was the teacher and the patient visible to students over the internet, but also there was a way of not just projecting the x-rays and the other laboratory results, but giving a more hands-on, almost literally, impression of how the patient was, and so on and so on. So it was much improved compared with what could have been done at a distance before. The thing that disturbed me was a comment by the journalist, not by the doctor, but by the journalist writing about this in the newspaper, who was saying that, of course, during a pandemic like this, no one who is not essential should be in the hospital. And the journalist went on, and obviously medical students are not essential. I think this is completely wrong. Medical students are absolutely essential, because it is essential that with care and with the safe precautions, that they see the cases that are coming through, that they learn how to perform their job. And so at the end of their course, they are actually able and properly educated to be able to qualify as doctors. If you were to take the words that the student is not essential to its conclusion, you might say that medical students should never be in the hospital until the moment they qualify. And then what would they know? So I think 4 points. We need to lead and help society think through all the things that have to be done to deal with the pandemic. We need to recognize that we've been here before and take lessons from the past experience. But what were medical students during the influenza epidemic in about 1920? In the cholera pandemic in Germany in the 1890s, medical students were at the forefront. So we know that students in the past have been there. My 3rd point is that we need to see what is going on, how things actually work. And we are taking the view that things should settle down adequately for us to be able to undertake accreditation properly and for us to make a good assessment of how accrediting agencies are working. And finally, I said that medical students are essential, and medical students are the most important people around where we are in education. So thank you. It's been a pleasure to talk, and I'm looking forward very much to the discussion, and I'm now happy to pass back. Thank you.
Muchas gracias, doctor Gordon, por los 4 puntos presentados. Seguramente más adelante tenemos la oportunidad de platicarlos con detalle. A continuación le pediría a la doctora Irene Durante, secretaria general de la Facultad de Medicina y presidente de COMAEM, nos haga favor de hacer su presentación. Adelante, Irene, por favor, y muchas gracias.
Muchas gracias, buenos días a todos. Espero que ahí ya estén viendo la pantalla. Y bueno, lo primero que quiero hacer es agradecer al doctor Pinsky, al doctor Gordon y a Martin Hart por estar aquí con nosotros y compartirnos la visión que ellos tienen de la acreditación internacional y de cómo la desarrollan. Entonces, en este webinar de retos de la educación médica en tiempos de COVID, vamos a ver, permítame, ahora sí. Vamos a pasar a ver lo que es la importancia de la acreditación internacional. Entonces, para ello tenemos una historia internacionalmente quizás no muy larga, pero sí muy intensa y con lo que nosotros consideramos buenos resultados. Hace 25 años, COMAEM, en ese momento manejado por ALAFEM, la acreditación, se logró acreditar el primer programa de educación médica en México. En el 2002 se conformó COMAEM, logrando la certificación de COPAES. Y como ya mencionó el doctor Gordon, en el 2006 se emite esta resolución orientada a incrementar la calidad y capacidad de los profesionales de la salud. Y entonces, COMAEM muy comprometido con el trabajo que tiene que ver con acreditación, muy comprometido con elevar la calidad de la acreditación, desarrolló un sistema en línea que se aplicó por primera ocasión a un proceso formal en el 2018. Ese mismo año, COPAES nos dio el refrendo de el reconocimiento otorgado a un organismo acreditador. Y un año después, en el 2019, con ese primer proceso llevado a cabo en línea, logramos el reconocimiento de la Federación Mundial como organismo acreditador, que lleva implícito y más bien explícito el aval para la acreditación internacional. ¿Cómo estamos hoy en día? Pues hoy en día en México tenemos 97 programas acreditados. Tenemos un programa acreditado en Costa Rica. En proceso de autoestudio, tenemos 28 programas en México y 8 programas en diferentes países de América Latina. Pero también tenemos 15 instituciones que se han interesado por ver el desarrollo de la autoevaluación y atinándole hacia la acreditación internacional. Y para ellos se organizan cursos de inducción. Todo esto lo podemos hacer con la participación de 162 académicos, quienes hacen la evaluación de los programas académicos. Además, tenemos 10 programas en América Latina que se interesan y están valorando la decisión de inscribirse a la acreditación internacional. Pero bueno, como ya se mencionó, la COVID-19 nos ha cambiado el mundo, cómo trabajamos. El día de hoy estamos reunidos a distancia debido a ello, pero también nos ha traído grandes enseñanzas. y una de ellas es que tenemos la capacidad de adaptarnos, tenemos la resiliencia para hacerlo y también de poder adoptar nuevos mecanismos. Entonces, el 29 de julio, la Asamblea del COMAEM decidió tomar un acuerdo para los procesos de reafirmación de la acreditación en tiempos de COVID. Y este acuerdo tiene los siguientes componentes. La Asamblea de COMAEM decidió extender el plazo de la vigencia de la acreditación de los programas de educación médica por 7 meses a partir del 11 de marzo, lo cual quiere decir que están cubiertos hasta el 11 de octubre. La realización a distancia de la evaluación por pares con fines de reafirmación de la acreditación a los programas se llevará a cabo para los que hayan cumplido con su plan de acción. Y a fines de este mes, o sea, en los próximos días, se dará a conocer el procedimiento y la programación de las visitas de evaluación a distancia. Cabe mencionar que tenemos 9 escuelas y que a ellas ya se les ha informado al respecto. Pero, como todo esto va cambiando, la Asamblea del COMAEM se asumió la responsabilidad de revisar este acuerdo en cada sesión programada con fines de actualizarlo. ¿Esto qué quiere decir? Pues nos reunimos a fines de septiembre y se valorará si debemos hacer algún cambio para actualizar este acuerdo o no. Tenemos 9 procesos programados para este segundo semestre. Ya tenemos un curso en línea para los detalles que tienen que ver con la evaluación en línea y va dirigido a nuestros evaluadores. Y también ya tenemos un procedimiento en línea que se da a conocer a las escuelas y a los evaluadores. Con esto, pues les damos las gracias y estaremos atentos a los cambios que se vengan, porque definitivamente esto va cambiando. Muchísimas gracias.
Muchas gracias, Irene, por tu presentación y por el papel que estás haciendo al frente de COMAEM en esta nueva etapa de acreditación internacional, no solo hacia el interior del país, como bien lo mencionas, sino también hacia Latinoamérica, particularmente hacia Centroamérica, en este caso Costa Rica. Hay varias preguntas en el chat, tenemos tiempo todavía. Yo quisiera empezar haciendo una pregunta a cada uno de nuestros panelistas de lo que hemos escuchado. Y le preguntaría yo a Marty Hart, en principio, de acuerdo a su presentación, que no estuvimos dormidos, ya la habíamos escuchado, pero no estuvimos dormidos, ¿no? ¿Cómo hacen en el Reino Unido para determinar el número de alumnos que necesita el país? ¿Cada escuela decide el número de alumnos o hay una planeación general, hay una planeación conjunta del sistema de salud con las instituciones educativas? ¿Cómo se decide esto en el Reino Unido?
Okay, well, I see David got very excited at that question. It's a very topical question to ask at the moment. I think traditionally the UK has relied very heavily on doctors from overseas. So going back 40 or 50 years, we recruited a lot of doctors from Southeast Asia, particularly India and Pakistan. More recently, of course, until the end of this year, we have been a member of the European Union. So we have had quite a large supply of doctors who have come to work in the UK from Europe. So in fact, in terms of the numbers of doctors we have trained, although it has grown slowly over the last few years, it's actually been relatively stable. I said about 40,000, it's increased periodically. We are, we are looking at whether we should be training more doctors. Interestingly, this year we have had, as you may or may not have heard, had a lot of challenges with our examination system, with our A-level system, and it looks as though as a result of that, because of the way students have had their grades calculated, that we're actually going to train rather more doctors this year than we have in previous years, and there's a lot of toing and froing going on at the moment about where we can train them, where we can afford them. I should say this is nothing to do with the GMC, so actually David may have a view on this as well, but the number is, is very much a political thing. Doctors are expensive to train, as I'm sure you know, and we have a tradition of students paying a relatively small amount of the total cost of their tuition here. Students tend to pay around about £9,000 per year over those 5 years, so just under £50,000. The cost of training a doctor is estimated at perhaps between £150,000 and £200,000. So it's a big economic question. Sorry, that's a long way of answering your question, but it's not perhaps as systematic as you might have thought.
Muchas gracias, Marty. Para el doctor Pinsky, nos preguntan si con la llegada del presidente Trump, estas políticas cambiaron para el acceso de médicos a Estados Unidos. Esa sería la primera pregunta, y si creen que esto pueda cambiar en el futuro. Adelante, doctor Pinsky.
Sure. Thank you very much for that question. And it's a question I hear frequently, and it's a question I ask myself frequently. I've sort of had a free-floating anxiety for almost the last 4 years as to what's going to come out of Washington. Fortunately, the career people in the Department of State, which is the agency that has a lot to do with processing visas. The career people understand the issues in healthcare and the issues of diversity and the issues of quality patient care. And with every proclamation or executive order that comes out of the White House, we've been able, through communication with the Department of State, to have healthcare workers excluded from that executive order. Even over this last 4 or 5 or 6 months. In fact, we had 4,400 doctors who were chosen in the residency match in March. And despite the pandemic, including air travel disruption, as well as a lot of sort of noise that came out of Washington, we had 94% of those individuals arrive to start their training by the end of July, which was remarkable. And that's because the Department of State facilitated consulates and embassies around the world to validate the credentials for people, for physicians coming into the United States. So we're very pleased with that. So anything can always happen, but I believe that there will be no disruption for physicians going forward. Now, depending on the election coming up in November, there could be a change in administration, but there might not be also. But I feel relatively secure because of our relationship with the Department of State.
Ujú.
Muchas gracias, doctor Pinsky. Otra pregunta para usted. Si la escuela en la que yo estudio medicina, por algún motivo, decide no acreditarse internacionalmente, ¿esto significa que no hay manera a partir de 2024 que el alumno, que el médico pueda hacer la residencia? ¿O habrá alguna otra puerta por la que el alumno pueda ingresar?
Thank you for the question. And this is another question that I've heard frequently as well. The reason that the Board of Trustees of ECFMG in the year 2010 passed a resolution that by 2023, ECFMG will only consider graduates of accredited schools that have been recognized by an agency to be doing the proper work. The reason that that was put in place is because of the wide variability of medical education around the world and the desire that individuals with proper education and training be involved in patient care. So that's how this whole process got started. We also recognize that many countries have adopted this, not because graduates even come to the United States, but because they see it as a way to help improve medical education, which we're always trying to do no matter what country we're in, and see that as a way to also improve healthcare in that country. So for all of these reasons, in 2024, if an individual is graduating from a medical school that is not accredited by an agency that's recognized by WIFME, as it stands right now, they will not be able to apply for a residency or fellowship training program.
De acuerdo, muchas gracias, doctor Pinsky. Para el doctor Gordon, no sé si quiere hacer algún comentario en relación a la primera pregunta de planeación, que lo vi haciendo algunos ademanes en relación a cómo planear a los recursos humanos y a los médicos en particular en las escuelas y facultades de medicina. Y la pregunta concreta que nos hacen es, ¿qué estrategias recomienda la Federación Mundial para la educación médica, la parte clínica en particular, en época de COVID? Muchas gracias, doctor Gordon.
Thank you. I think I would find it difficult to go much beyond what I said before, and that is that we need to see what is possible to keep things as close to normal practice as possible. When I was a medical student, we studied in infectious disease wards. We studied in what in those days were called fever hospitals. And when we went to the fever hospital, measures were taken care of that we did not catch the same fever. So we've got to be able to try and teach with protection from infectious agents. But of course, it is never possible to provide 100% protection. We have to understand that medicine and studying medicine is not a risk-free process. But we would argue for, as far as possible, keeping education active and as close as it can be to the normal model. And certainly we would very much dislike the idea of students not being essential. As I say, medical students amongst the medical workforce in the hospital are one of the most essential groups. I will, if I may, just follow on the answer that Martin gave earlier on about numbers of medical students, because I think this is a very difficult and complicated question. And I think he was perhaps not being as supportive as I would be of the General Medical Council, because I think over the decades, the General Medical Council has led in making sure that there is really careful thought about the number of students. Educating too few medical students is obviously a mistake. Educating too many is also a mistake, because education of doctors is expensive. If you educate too many, then you are wasting national resources. And if you educate more doctors than you can accommodate in your healthcare system, then there will be unemployment of medical doctors. And that's damaging for the young people involved, and also, as I say, a waste. Some years ago, around more than 20 years ago, just before I became the dean of a medical school, the UK had a system where the Department for Health and the Department of Education worked together to think through the numbers of medical students that might be needed. And I was able, when I was based in Denmark, to write a paper with a Danish colleague, Dr. Engelbrecht, about comparing the British and the Danish systems. And our conclusion was that the profession on the whole is quite good at thinking through the numbers and looking at trends in medical practice that will increase or decrease the number of doctors you might need. The difficulties come in when governments make ill-advised interventions or do something wrong that then has a knock-on effect on the numbers of medical students. The problem in the UK at the moment is that the British government handled school examinations very badly. And because of their mistakes in doing that, now there are numbers of school leavers qualified to go to medical school that will be difficult for medical schools to accommodate. Now, they have got to be treated fairly, and I'm sure the medical school system will do so, but we have to be careful that the government thinks through the employment questions that will come up 5 or 6 years down the line. So I think it's never an easy question. The profession is good at thinking things through on the whole, and ill-judged interventions from governments are the most dangerous.
Muchas gracias, doctor Gordon. Para la doctora Durante, nos preguntan, ¿qué debe hacer una escuela no mexicana para acreditarse por COMAEM?
Muchas gracias por la pregunta. Pues una escuela que desee participar en el proceso de acreditación con COMAEM, lo que tiene que hacer es, uno, puede entrar a la página de COMAEM y contactarnos, ya sea por teléfono o por correo, o dejar un mensaje en la página. Y nosotros, en respuesta, nos contactamos con ellos si es que el comunicado no fue telefónico. Y empezamos la plática de qué implica, qué se requiere, cuánto tiempo puede o no tomarla la escuela y qué importancia tiene la acreditación internacional. Entonces, el correo es comaem.acredita@gmail.com y la página es comaem.org.mx. Gracias.
Muchas gracias, Irene. Estamos ya a 11 minutos de terminar. Yo les pediría un comentario final a cada uno con una pregunta que nos han hecho, que es cómo homogeneizar la educación médica y qué beneficios tiene esta acreditación internacional para el estudiante de medicina que no quiere hacer el examen para irse a Estados Unidos, para el estudiante para los miles de estudiantes que se quedan en sus países. ¿Qué beneficios tiene la acreditación internacional? También es otra de las preguntas. Yo empezaría, como iniciamos esta presentación, con Martin Hart, con su comentario final, y si puede dar respuesta a una de estas preguntas. Adelante, Martin, por favor.
So actually, I think there's a balance to be struck between international accreditation and meeting the needs of individual countries. And your question to me was very acute about, you know, the responsibility of a nation to train the right number of doctors for its own population. I do think international and the work that David does, and the fact we're all joining this call, we can learn a lot from each other and understand what is going on in medical education around the world. But we have to balance that with the needs of our own country and the work I've been doing with colleagues in Mexico. I've certainly learnt an awful lot from them. I hope they may have learned a little bit from me as well. So it's a balance between a country's needs and the internationalization of medicine. I do think David's point about the role of doctors and getting that balance right. There are new roles coming into healthcare. Doctors' roles is always changing, and as we said, doctors are expensive. We need to train the right number, and I think importantly, get them to do the things that really only doctors can do, which is probably to do with dealing with the uncertainty and differential diagnosis and things like that. It takes a long time to train a doctor as well. I think that's something, again, picking up David's point with government trying to turn on and off the supply. You saw my slide with the length of time it takes to train a doctor. It takes a minimum of 10 years to get a doctor to be fully trained, and this isn't something that can be done quickly. And perhaps my final point, which I think is linked to the COVID point as well, it's vitally important that we carry on training our doctors through any future pandemics or spurts. And we've just written to government to remind them of this. Like many countries in the world, when we had the immediate lockdown, we sent all our students home. We took them out of their clinical environments. In the event of future waves, that cannot happen again, because actually our supply of doctors is very fragile, and we need to make sure that each year about 7,000 doctors finish medical school, having met all their outcomes, having reached the appropriate standard to be safe for patients. So it's a very fragile balance to be struck, but I think we do need to work in these international communities, but inevitably reflect on the individual needs of our countries. Sorry, a very garbled answer to your question, but I hope it's some food for thought.
No se te escucha tu micrófono. Ahora sí.
Adelante, doctor Pinsky. ¿Algún comentario final y alguna aproximación a las preguntas?
Okay, good. All right, I was waiting for a cue. I agree with most of Martin's garbled remarks. I'm using your word, not my word. It comes down to it's all local. I think in terms of what countries need and that sort of thing. When I came into my role at ECFMG 4 years ago, the process for the International Accreditation Recognition Program was well underway. David had WFME organized, and the process was in place. And as I learned about it, I recognized why United States and ECFMG had asked for this requirement. But as I traveled around the world and met with many of you who are on this call, as well as people in Africa, Asia, it became apparent to me that the major impact of this accreditation recognition program is a way to have what I would call a process improvement in our medical school. As Martin mentioned, it's sharing ideas, it's meeting people, and recognizing how we can all raise the standards, because a rising tide floats all boats. I used to have a slide that showed that. And by raising standards, it's at least one variable, as I mentioned earlier, that can help to improve the delivery of healthcare. So in my mind, the reason for countries to be accredited and recognized not to send graduates to the United States for training. I do believe in our training programs, and I think we do an excellent job of training. And I think the diversity of having people come from around the world is extremely important. And I want to see that continue. But the real importance, I think, is being able to recognize how standards can be raised. And that's doesn't mean that countries should be told how to educate. It's the standards part, because cultures are different, and the way the standards get applied in Latin America versus Africa versus Western Europe versus US versus wherever, it can be very different because the cultures are different. It's the standards and the expectations of what the outcomes should be that is really important. And I can tell you personally, I'm personally very affected by COVID in the sense that in the last 4 years, I've gotten to be able to travel and meet so many people and learn so much. And I think these video conferences are excellent and very helpful. It's still not the same as you know, being in the conference and then sitting down after after we do the talks today, and you know, sharing a meal, a drink, whatever else, and talk about things. And I think that's as important as anything else. And I feel, or I did feel prior to COVID, that the enthusiasm around the world for this accreditation recognition process was really being embraced, because people saw it as a way of sharing ideas and a performance improvement activity. And I think it's David's turn now.
Yes, and if I may, I'll say 4 things quite quickly. 3 of them relate to the question about how do we homogenize medical education? How do we make it uniform? And my first answer is that it must not be uniform, because there are 2 major factors that cause variability properly. One is geographical, from place to place. A medical student in Azerbaijan needs to know a very great deal about drug-resistant tuberculosis. A medical student in Australia needs to know a great deal about hydatid disease. Both students need to understand the other, but they do not need to have uniform knowledge. The other point related to homogeneity, what is the value of international recognition of accreditation? I'm very much following Dr. Pinsky here. I think it is very striking to us that some countries that have come to us with a relatively new accreditation system are countries that do not export a lot of doctors, but they developed it to increase the standard locally. A good example, and I'm sure they will not mind me mentioning them, is in Japan. Japan exports very few doctors, but they have an absolutely excellent accreditation system, and that has allowed them to do things in 1 or 2 specific places that were really necessary to do to bring up the standard. So those are my 3 points about homogenizing education. A 4th quick point, just following on the question about COMAEM working in other countries, which we support where it's appropriate in other relevant local cultures. But for example, the Costa Rica example, we very much want the national government to recognize what COMAEM has done. And we are at the moment trying to persuade the government of Costa Rica. And if you're in a country outside Mexico, but you would like COMAEM to accredit your school, also try and persuade your national government to recognize what COMAEM does. Thank you.
Muchas gracias, doctor Gordon. Irene, un comentario final, por favor.
Sí, muchas gracias. Pues me parece, estoy de acuerdo con lo que han comentado. La razón última de un proceso de acreditación es poder lograr el mejoramiento y aseguramiento de la calidad de la educación médica. Los estándares no nos indican cuál es la morbilidad que debemos atender en nuestro país, pero sí nos indican con qué calidad deben de egresar los profesionales que van a atender esa morbilidad de nuestro país. Eso es lo que me parece de lo más importante, que los estándares permiten elevar la calidad de la educación médica, aunque el egresado no se vaya. Es más, queremos egresados de esa calidad en nuestro país. No los estamos preparando para que se vayan, sí para que tengan la opción. Muchas gracias.
Muchas gracias, doctora Durante. Yo con esto quisiera agradecer nuevamente al doctor Hart, al doctor Gordon y al doctor Pinsky, por supuesto a la doctora Durante, la participación en este seminario Retos de la Educación Médica en tiempos de COVID, la importancia de la acreditación internacional. Sin lugar a dudas, este tema de la acreditación, este tema de la garantía de la calidad, es un tema que tenemos que regresar frecuentemente para mejorar los procesos con nuestros alumnos. Yo quisiera agradecer a todos los que nos han visto y escuchado por las diferentes redes sociales e invitarlos también a nuestro siguiente seminario también sobre retos de la educación médica en tiempos de COVID, particularmente decisiones institucionales frente a la pandemia, que se llevará a cabo el próximo 1 de septiembre. Sin más, yo quisiera agradecer a la UDUAL, agradecer, por supuesto, a quien la dirige y a Germán Ruiz, las facilidades para llevar a cabo este seminario. No sé, Tocayo, si tengas algún comentario antes de finalizar, sino agradecer nuevamente la ayuda y la participación conjunta en estos temas tan importantes para nosotros, que es la educación médica en tiempos de COVID.
Gracias, doctor Fajardo. Pues en nombre del doctor Roberto Escalante, siempre agradecer esta colaboración desde la ALAFEM, la UDUAL y todas las universidades en América Latina y el Caribe, y hoy en día que gracias a estas gestiones nos conectamos a otras partes del mundo. Agradecerles a todos los que estuvieron conectados y recordarles que también vamos a estar transmitiendo en nuestras redes sociales, y este mismo webinar quedará también en nuestros canales informacionales de redes sociales. Muchas gracias, doctor Germán Fajardo, y estamos muy contentos de participar nuevamente. Agradecer todo el apoyo técnico también de la gente que apoyó la traducción simultánea, a la Facultad de Medicina, que han estado también muy al pendiente para que esta sesión se lleve a cabo. Gracias, doctor, y estamos aquí. Hasta la próxima.
Muchas gracias a todos.
Gracias a todos. Muy bien.
Great to see you.
Bye bye.